Are the slides visible now?
Yes, sir.
Okay.
Yes, sir.
So yesterday we have seen the normal cardiac cycle, and then how the connect the various electrodes, and what is hypovenous triangle, and what does the chest leads indicate. Now we also started discussing about what a 12-lead ECG will tell us. As I told you, 12-lead ECG consists of a P wave, QRS complex, and a T wave. Very certain times a U wave is seen. Impulse conduction, whenever from synaptic node to AB node and bundle of it comes, you get P wave, and when it comes to bundle branches, QRS complex is formed. So we have seen P wave and its variables yesterday, and we have discussed about PR interval. See, PR interval, rise in PR interval occurs in the heart block. Now coming to the QRS complex, it is the sequence of deflections due to ventricular depolarization. Whenever ventricle depolarize, your QRS complex is formed. It has three waves: Q wave, R wave, S wave. Q wave is the first negative deflection of QRS complex. That means this wave will be below the isoelectric line. R wave is the first positive deflection of QRS complex. That means this wave is present above the isoelectric line. S wave is again a negative deflection. That is, it is below the isoelectric line. Now the duration, it is from the beginning of Q wave, that is the negative deflection, to the end of S wave, that is the second negative deflection. It is 0.08 to 0.1 second. As I told you, one large square means 0.2 seconds. So 0.1 second means it should be within half of the whole QRS complex should be within half of one large square. In limb leads, the ECG machine is arranged so that when a depolarization wave spreads towards a lead, the stylus moves upwards, that is a positive deflection. When it spreads away from a lead, the stylus moves downwards, that is a negative deflection. If the QRS complex is predominantly upward or positive, that is R wave is greater than S wave, the depolarization is moving towards that lead. If predominantly downward, see, if QRS complex R wave is greater than S wave, QRS complex. If R wave is bigger than your S wave, okay, then that means into that, but suppose this type of QRS complex is seen in lead 1, it indicates that the wave is moving away from the lead 1. If predominantly downward or negative, that is S wave is bigger than R wave, then it indicates the depolarization is moving away from that lead. If it is positive, it is moving towards that lead, and if it is negative, that means S wave is greater, then it is moving away from that lead. When the depolarization wave is moving at right angles to the lead, then R and S waves are of equal size. Normal cardiac axis is downward and to the left. That is, the wave of depolarization travels from the right atria towards the left ventricle. When an electrical impulse travels towards a positive electrode, there will be a positive deflection on the ECG. That means an upright deflection will be seen. If the impulse travels away from the positive electrode, a negative deflection, that is a downward deflection, is seen on the ECG. Now see, this is how our leads are arranged. Limb leads, AVR, AVL, AVF, 1, 2 and 3. Lead AVR and 2 look the heart in opposite direction. This is AVR and this is lead 2. They loop the heart in opposite directions. Seen from the front, the depolarization wave normally spreads from the ventricle from 11 o'clock to 5 o'clock like this. It spreads in this way, left side. So when an action for electrical impulse travels from AVR and moves towards lead 2, it is moving away from AVR. That's why you get a negative deflection at the AVR. That means in AVR, the S wave should be longer than the R wave. And it is moving towards lead 2. So whenever an electrical impulse moves towards an electrode, there a positive deflection should be there. So in lead 2, your R wave should be longer than the S wave. The average direction of spread of depolarization wave through the ventricles as seen from the front is called as cardiac axis. So this 11 o'clock to 5 o'clock is called as cardiac axis. The direction of the axis can be derived most easily from QRS complexes in lead 1, 2 and 3. A normal 11 o'clock to 5 o'clock axis means that the depolarization wave is spreading towards lead 1, 2 and 3, and therefore upward deflection is seen in these leads. Here you have to understand, doctors, upward deflection means R wave. R wave is dominant. When compared to the S wave, R wave is dominant in lead 1, 2 and 3. And the deflection will be greater in lead 2 than 1 and 3. In lead 2, it will be more predominant because it is directly in opposite. The wave comes exactly towards the lead 2. That's why the deflection will be more in lead 2 than when compared to 1 and 3. So here R wave is dominant. Suppose if there is right ventricle hypertrophy, that means the right side of the heart has been increased, the axis will swing towards the right. Whichever heavier side, the axis will start swinging. So when the right ventricle is hypertrophied, the axis will swing towards the right. The deflection in lead 1 becomes negative. Now see, so suppose right ventricular hypertrophy is there. If it is going the wave, if the wave is traveling like this towards, because right side is more, it goes towards the lead 3. So then what happens? Lead 3 and lead 1 will be in opposite directions. So the wave is going away from lead 1 in right ventricular hypertrophy. So in lead 1, there will be S wave dominance. This is called right axis deviation and is associated with pulmonary conditions and in congenital heart disorders. Now suppose if a left ventricle is hypertrophied, the axis may swing to the left side. So the QRS complex becomes predominantly negative in lead 3. So again, if there is a left axis deviation, that means if left side hypertrophy is there, the electrical impulse will move towards the 1. So lead 3 will become opposite to lead 1. So the impulse is traveling away from the lead 3. So in lead 3, you get a negative response. This is called as left axis deviation. Left axis deviation is not significant until QRS deflection is also seen in lead 2. Please understand. Alone in lead 3, if you find out left axis deviation, you cannot come to a conclusion. There should be deviation also in lead 2. And the problem is mainly the conduction defect rather than the left ventricular hypertrophy. If only lead 3 deflection is seen, if only lead 3 deflection is seen, it is mainly conduction defect. But if you see left axis deviation in both lead to 3 and lead 2, then it is left ventricular hypertrophy. Now, we have seen how the QRS complex appear in limb leads. Now, let us go into the chest leads. How the QRS complex appears in the chest leads. We have 6 chest leads, V1, V2, V3 to V6. Now, in this, as I told you, if you remember, let's go back once. Here, if you see the electrodes, V1, V2 are looking towards the right ventricle. Please, this point is very important. Otherwise, you will not understand. Concentrate here. V1, V2 look at the right ventricle. V3, V4 look at the septum, interventricular septum. V5, V6 look at the left ventricle. V1, V2 right ventricle. V3, V4 septum. V5, V6 on the left ventricle. Now let's go to the QRS complex in the chest leads. Yeah. The shape of the QRS complex in the chest leads is determined by the septum between the ventricles is depolarized before the walls of the ventricles. And the depolarization wave spreads across the septum from left to right. In normal heart, there is more muscle in the wall of the left ventricle than in that of the right ventricle. Hence, left ventricle has more influence on the ECG pattern than on the right ventricle. Now, lead 1 and V1 and V2 look at the right ventricle. Lead V3, V4 look at the septum, that is interventricular septum. Lead 5 and lead V6 look at the left ventricle. Now, what happens in stage 1? In a right ventricular lead, the deflection is first upwards, R wave, and as the septum is depolarized. In a left ventricular lead, the deflection is first downwards. There is a small Q wave called septal Q wave. In stage 2, in a right ventricular lead, that is V1 and V2, there is then a downward deflection as the main muscle is depolarized. In a left ventricular lead, there is an upward deflection, R wave, as the ventricular muscle is depolarized. When the whole of the myocardium is depolarized, the ECG returns to baseline. The QRS complex in the chest lead shows a progression from V1, which is predominantly downward, to lead V6, which is predominantly upward. That means in V1, your S wave will be very big and R wave will be very small. Now, once you go towards the V6, the size of the S wave will start decreasing and the size of the R wave will start increasing. And when it comes to lead V6, there is a dominant R wave and a very recessive S wave is seen. Now, there is a transition point where S wave and R wave are of equal sizes. Again, I am repeating, please understand. When the depolarization wave travels from V1 to V6 in chest leads, there is a transition from V1 to V6. At the baseline V1, the R wave will be very small, S wave will be very big. Then when it comes to V2, R wave size slowly increases, S wave size slowly decreases. Like that, slowly R wave will be increasing in size and S wave will be decreasing in size. When it comes to the V6 electrode, Completely, R wave is very dominant and S wave is very recessive. But in between, there is a transition point where R wave and S wave are of equal sizes, and that indicates the interventricular septum. That is, always you should get this transition point in between V3 and V4. If suppose there is left ventricular if there is change in V3 and V4, the R and S wave should be of equal size. Because as previously we have seen, lead V3 and V4, look at the interventricular septum. Now, if the right ventricular is enlarged, what happens? And occupies more of the pericardium than normal, then the transition will move towards V3 and V4. Two leads, V4 and V5. Slowly, it may even shift to V5 and V6 seen from the below. The heart can be V3, V4 to V4, V5 or V5, V6 indicates chronic lung diseases. Abnormal wide QRS complex indicate the presence of bundle branch block or extrasystoles. Suppose, as I told you, it should be completed within 0.08 to 0.1 second. That is, half of the large square it should be completed. Very wide QRS complexes. Suppose if you are seeing 0.2 second QRS complex, that is occupying one large square, then it indicates bundle branch block or extrasystole. If the height of the QRS complex is abnormally high, then it indicates an increased muscle mass either of the ventricle, left ventricle or right ventricle. Q waves greater than one small square in width and at least 2 millimeter deep indicate myocardial infarction. Your Q wave, if it is one small square in width, completely one small square in width, and 2 millimeter deep, it should not be 2 millimeter deep. Means below the isoelectric line 2 millimeter. One block indicates 1 millimeter. To 2, if it is more than 2 millimeters, it indicates myocardial infarction. Next, coming to the ST segment, this is the interval between the end of S wave and beginning of T wave. Normally, it is isoelectric, that is on the same line of the RQ segment. Depression by half millimeter or elevation by 1 to 2 millimeter is normal. More than that indicates myocardial infarction. Now, let us see the variants of ST segment. Elevation of ST segment indicate acute myocardial injury, usually due to recent infarction or due to pericarditis. If ST segment elevation indicate acute myocardial injury, suppose you have taken an ECG and you have observed on any lead ST segment has been elevated, it should be along with the isoelectric line. But if you see ST segment associated with an upright T wave is usually sign of infarction. Horizontal depression of ST segment, that is what horizontally it is below the isoelectric line. With an upright T wave, it is usually sign of infarction, myocardial infarction. When the ECG at rest is normal, ST depression can be seen during exercise because exercise can induce angina. See, usually many times many cardiologists also miss this point. Patient will be having breathlessness, any symptoms of the myocardial infarction. But when we take a resting ECG, we find normal findings. So that's why actually, if you really want to find exact whether the patient is suffering from coronary artery disease, exercise ECG is important, because in exercise ECG, this ST segment changes will occur clearly when compared to the resting ECG. Downsloping as opposite to horizontal depressed ST segment are usually due to treatment of digoxin. Suppose if the patient is on digoxin, cardiac glycoside, digoxin is cardiac glycoside, then there will be downsloping of the ST segment. Then T wave, it is the deflection following the QRS complex and is produced due to ventricular repolarization. Ventricular repolarization should be in the same direction as and smaller than the QRS complex. Shape asymmetrical gradual upstroke and a steep downstroke. Inverted T wave. The inverted T wave is seen in following conditions. In leads AVR and V1, it is normal. If you say an inverted T wave in AVR and V1, it is considered as normal. In other leads, AVL, AVF, V2, V3, V4, V5, V6, if you see an inverted T wave, it indicates ischemia, ventricular hypertrophy, bundle branch block, or normal QT interval is less than 0.42 seconds. Variations. Short QT interval is seen in electrolyte abnormalities. Now, counting of heart rate. Usually, how to count heart rate on ECG? Relationship between the large number of large squares covered by R to R interval and heart rate can be found. Suppose if between two R waves, one large square is there, that means heart rate is 300. If two large squares are there, heart rate is 150. 3, it is considered as 100. 4, 75. 5, 60, 650. There are other formulas also to calculate the heart rate by using not present at rest and to determine adequacy of cardiac function. So usually, as I told you, at rest, maybe the patient is their exercise is induced. Exercise ECG, one of the most frequent non-invasive modalities used to assess patients with suspected or proven cardiovascular diseases. Estimate likelihood and extent of coronary artery disease, the prognosis, determine functional capacity and effects of therapy. We don't only do exercise ECG for the first time identification of coronary artery disease. We repeat the test to check the prognosis. Suppose patient had a PTCA, percutaneous balloon angioplasty, which we call it as PTCA, or CABG, coronary artery bypass graft, or patient is on digoxin, or patient is on any cardiac drugs. So to check the prognosis and to find the functional capacity and effects also, we will do this exercise ECG. So we have exercise. To understand this, we need to know the exercise physiology. What are the protocols that are to be determined? Electrocardiographic measurements, how to do it. Non-electrographic observations, observing the patient when doing this test. What are the indications? Specific clinical applications, safety and risk, and termination of exercise. These are the things you should know. Now, first, exercise physiology. Exercise body's most common physiological stress places major demands on the cardiovascular system. Exercise considered most practical test of cardiac perfusion and function. Fundamentally, it involves the measurement of work. Common biologic measure of total body work is oxygen uptake. Cardiac output can increase as much as 6 folds during an exercise. Normal cardiac output is 5 liters per minute. Acceleration of heart rate by vagal withdrawal, increase in arterial alveolar ventilation, increased venous return, sympathetic vasoconstriction. Early phases cardiac output is increased by augmentation in the stroke volume and heart rate. Later phases by sympathetic mediated increase in the heart rate. During strenuous exertion, that is exercise, sympathetic discharge is maximal and parasympathetic stimulation is withdrawn. So there is vasoconstriction of most circulatory body systems except in the exercising muscle, cerebral and coronary circulations. So whenever the exercise limits are high, there will be vasoconstriction in the other circulation, hepatoportal circulation, pulmonary circulation, everywhere. Only the exercising muscles, cerebral brain and coronary circulation to the heart are vasodilated. Catecholamine releases enhances ventricular contractility. So in the body, catecholamines are released and it increases the ventricular contractions. As exercise progresses, skeletal muscle blood flow is increased. Oxygen extraction increases by as much as 3-fold. Total calculated peripheral resistance decreases because of vasodilatation. Total body or ventilatory oxygen uptake, amounts of oxygen extracted from air as the body performs work. The VO2 max depends upon the cardiac output and peripheral atriovenous oxygen difference. Maximal AV difference is constant, that is 15 to 17 milliliter per decaliter. VO2 can be estimated from treadmill speed and grade. VO2 is calculated by the treadmill speed and grade. MPH into 2.68 into 0.1 in plus grade into 1.8 plus 3.5. Grade is the elevation. VO2 can be converted to METs by dividing it by 3.5. MO2, myocardial oxygen uptake, is the amount of oxygen consumption by the heart muscle. The determinants of MO2 is intramyocardial wall tension, that is contractility and heart rate. MO2 is estimated by using heart rate and SBP, systolic blood pressure. Exercise-induced angina often occurs at the same. The maximum heart rate is calculated by a formula 220 minus age. Overestimate maximum heart rate in females, MHR is equal to 206 minus 0.88. MHR is decreased in older persons. Age predicted maximum heart rate is a useful measurement for safety reasons. Post-exercise phase, hemodynamics return to baseline within minutes. Vagal reactivation. Important cardiac deceleration mechanism after exercise, accelerated in athletes but blunted in chronic heart failure. Metabolic equivalence refers to a unit of oxygen uptake in a sitting resting person. Common biologic measure of total body work is the total oxygen uptake. 1 MET is equated with the resting metabolic rate. MET value achieved from an exercise test is a multiple of the resting metabolic rate. MET is associated with activity is equal to measured VO2 by 3.5 both in ml oxygen per kg per minute, measured directly or estimated from the maximum workload achieved using standardized equations. So this is the calculation of MET on the treadmill, which we already discussed. But you need not calculate this. This will be automatically calculated by the TMT device. Clinically significant. If the patient has 2 METs level walking at 2 miles per hour, 4 METs level walking at 4 miles per hour, less than 5 METs poor prognosis, peak cost of basic activities of daily living, 10 METs prognosis with medical therapy as good as coronary artery bypass surgery, unlikely to exhibit significant nuclear perfusion defect. If the patient is able to do 13 METs, excellent prognosis regardless of other exercise responses. 18 METs, elite endurance athletes, 20 MET world-class athletes. Exercise test modalities, isometric, dynamic, and a combination of two. It can be isometric, it can be dynamic, or combination of two. Isometric exercise, constant muscular contraction without movement. Dynamic protocols are most frequently used to assess cardiovascular reserve. Should include a low intensity warm up and a recovery or cool down period. It is optimal for diagnostic and prognostic purposes, that is for the prognosis. Approximately 8 to 12 minutes of continuous progressive exercises are given. Myocardial oxygen demand elevated to patient's maximum. It can be checked by arm ergometry, bicycle ergometry, treadmill protocol, or walk test. Arm ergometry involve arm cranking at incremental workload of 10 to 20 watts for 2 to 3 minute stages. Heart rate and BP responses to a given workload more than leg exercise. Peak PO2 and peak HR, 70% of leg testing. Bicycle ergometry involve incremental workload starting at 25 to 50 watts, lower maximal VO2 than the treadmill. Treadmill protocol, we use Bruce protocol. Mostly we use Bruce protocol, very commonly used, or modified Bruce protocol. Norton and Weber, asymptomatic cardiac ischemia pilot trial ASIP and modified ASIP. Bruce multi-stage maximal treadmill protocol, 3 minutes periods to achieve steady state before workload is increased. Limitation, relatively large increase in VO2 between stages. Modified Bruce protocol, it is given in older individuals or those who exercise capacity is limited. Modified by 2-3 minute warm-up stages at 1.7 miles per hour. 0% grade. Here grade means elevation. If you see a treadmill, the treadmill can be elevated and down, inclined and declined height. Norton and Weber protocols use 1 to 2 minute stages with 1 MET increments between stages. Asymptomatic cardiac ischemia pilot trial and modified ACP trials use 2 minute stages with 1.5 METs increments between stages after 1 minute warm-up. Functional capacity overestimated by 20% if handrail support is permitted. Then walk test, this is very common, we also use in physiotherapy department. 6 minute walk test or a long distance corridor walk. Provide an estimation of functional capacity in patient who cannot perform bicycle or treadmill exercise. older patients, heart failure, claudication or orthopedic limitations, walk down a 100-foot corridor at their own, involve measurements of respiratory oxygen uptake, VO2, carbon dioxide production, VCO2, and ventilatory parameters during a symptom-limited exercise test. Patient wears a nose clip and breathes through a non-rebreathing valve. No caffeinated beverages or smoke 3 hours before. Wear comfortable shoes and clothes. Unusual physical exertion should be avoided. Brief history and physical examination is performed. Explain the risk and benefits to the patient, and informed consent is taken. 12 lead ECG is recorded. We already seen what is 12 lead ECG. With electrodes at the distal extremities. Torso ECG is obtained in supine and standing position. If false positive test is suspected, hyperventilation should be tested. Room temperature should be between 18 to 24 degrees centigrade and humidity should be less than 60%. Walking should be demonstrated to the patient. Heart rate, BP and ECG is recorded at the end of each stage. Resuscitator card, defibrillator and appropriate cardioactive drug should be available when you are performing this test. In case any emergency, you can help. Optimal patient position in the recovery phase, supine. Sitting position, less space is required and patients are more comfortable. Supine position increases end diastolic volume and has the potential to augment ST segment changes. Electrocardiographic measurements. Modification of the standard 12 lead ECG. Extremity electrodes move to the torso to reduce motion artifacts. Results in right axis shifts, increased voltage in inferior leads, loss of inferior Q waves, new Q waves in lead AVL. Types of ST segment displacement, J point or junction, depression, normal finding in exercise. In myocardial ischemia, ST segment becomes horizontal. With progressive exercise, depth of ST segment may increase. In immediate post-recovery phase, ST segment displacement is seen. PQ junction is chosen as isoelectric point. TP segment is true isoelectric point but impractical in choice. Abnormal ST depression 0.1 millivolt, that is 1 millimeter or more than ST depression from PQ junction with a flat ST segment slope. 80 milliseconds after J point, ST at 80 in 3 consecutive beats with a stable baseline. So this is all hi-fi, not required. This is all not required for you. Non-electrocardiographic observations. We require to check the blood pressure, maximal work capacity, heart rate responses, heart rate recovery, chest discomfort, rate pressure product. Normal exercise response increases SBP progressively with increasing workloads, ranges from 160 to 200, higher range in old patients with less compliant vessels. Abnormal, failure to increase SBP more than 120, sustained decrease greater than 10 mmHg, fall in SBP below resting values, diastolic BP doesn't change significantly. Conditions other than myocardial ischemia associated with abnormal BP response are cardiac myopathies, cardiac arrhythmias, LVOT obstructions, anti-hypertensive drugs, patients using anti-hypertensive drugs and hypovolemia. An exaggerated BP will increase with exercise. Important maximal work capacity, important prognostic measurement of exercise test. Limited exercise capacity, increased risk of fatal and non-fatal cardiovascular events. In one series, adjusted risk of death reduced by 13% for each 1 MET increase in exercise capacity. Estimation of peak functional capacity for age and gender known for most protocols. Heart rate response, sinus rate increases progressively with exercise. Inappropriate increase in heart rate at low work loads. Atrial fibrillation, physically deconditioned, hypovolemic anemia, and marginal left ventricular functions. So these are all not required for you. That's it. That's about your what do you call exercise treadmill test. Tomorrow we will see some assessment techniques and what do you call that? Chest radiograph. Okay.
Okay, sir.
Okay, sir.
Bye bye.
Sir.
Thank you, sir.
No.
मैम आप कुछ पूछ रही थी?
हाँ, डिस्कनेक्ट।
सॉरी मैम, मैंने इंट्रूड कर दिया।
अरे टाइम कल का, अभी कॉल करती हूँ।
अच्छा अच्छा,
चलो मीटिंग